Great, thank you. Welcome, everyone. This is Giovanna Giuliani from the California Healthcare Foundation. You have joined our monthly California Improvement Network webinar on ensuring safe and appropriate opioid use. There's been a lot of interest in this area from providers. It's a significant public health issue, and I know many organizations and health plans are working on improving the processes that they have in place to make sure that there's safer processes and that pharmacists in different parts of the care community are working together to address this issue. And so we wanted to bring this to you today from Kaiser Permanente, from the Southern California Permanente Medical Group, to showcase one organization's approach and story for this public health problem. For those of you who have just called in, please take a moment to complete the poll on the right-hand side of the screen. Just 3 short questions about who you are. A few housekeeping issues before we move on to the content of our presentation. I always get questions about whether or not the session will be recorded. It will be recorded, and both the slides and a link to the recording will be posted on our website within a week of today's event. We will also send out an email to those of you who registered for the webinar. You'll receive an email with the link both to the slides and the recording so that you can pass it on to others in your network, among your peers who might be interested in learning more about this topic and who were not able to join. If you have any questions, please, if you have a logistical or a technical question, you can just chat to the host. But if you have questions for the speakers, it would be great if you could use the chat function on the right and chat to all so that everyone can see your question. I'll be moderating that chat box, and we will likely just queue up questions at the end of the presentation when we have about 15 minutes left. I am really excited to introduce our wonderful presenters today. We're very lucky to have Dr. Joel Hyatt and Dr. Steven Steinberg from the Southern California Permanente Medical Group. And I'll just do a quick intro of each of our speakers today. Dr. Hyatt is an Assistant Regional Medical Director for SCPMG. He's a family practice physician, family medicine. He has held many community level and statewide level positions. On the first one is a member of the Los Angeles Free Clinic Board of Directors. He was also on the Health Services Advisory Committee for the Pacific Business Group on Health. And he's currently on the Integrated Healthcare Association's, the IHA P4P Advisory Committee, also on the National Business Coalition of Health Value-Based Purchasing, the Evaluate Advisory Committee, and on the Agency for Healthcare Research and Quality, the AHRQ Effective Healthcare Program and Regional Expert Panel. Dr. Hyatt's a graduate of Stanford University, and he completed his medical training and residency in family medicine at UCLA, and he continues to practice as a board-certified family physician. His current areas of focus include appropriate medication use management, medication adherence, and the value demonstration through public reporting and purchaser-employer engagement. Dr. Steven Steinberg is the Regional Chief of Family Medicine at SCPMG, and he's also the Chair of the Regional Controlled Substances Executive Work Group. He's held multiple positions within Southern California PMG, including Physician in Charge of Adult Urgent Care at Panorama City Medical Center and Regional Chief of Family Medicine. He attended the University of California at San Diego for medical school, and he also received the 2007 Kaiser Permanente Latino Association Unsung Hero Award. So thanks to both of you for agreeing to present your work. We're really excited for a very substantive presentation, and we look for some interesting dialogue. Folks who are on the phone, please feel free to queue up questions in the chat function so you don't forget them, and I'll kind of combine similar questions and moderate the conversation at the end. And so with that, I am going to turn it over to Drs. Hyatt and Steinberg.
Well, hello, everybody. This is Joel Hyatt, and Steve Steinberg's here with me. And we're really excited about having this conversation with you and to walk you through our journey and the story that we've been experiencing in addressing this problem I think we're all familiar with, this epidemic of opioids in our community. What we're going to be talking about today is starting out with how we discovered that we had a problem, even in Kaiser Permanente. We're going to talk briefly about the epidemic of prescription opioids in the U.S. and talk a lot about the evidence-based approach to opioid prescribing, which really drives all of the intervention strategies and tactics that we have put together within our organization. We will then share some of the results that we've had to date, talk a bit about the lessons we've learned, which may be applicable to you and your organizations, and then talk a bit about the call to action, where we recognize this is a community-wide problem, and we share this problem, and we all have opportunities to improve care. This slide is the obligatory Kaiser Permanente slide. Just for those of you who may not have heard of Kaiser Permanente, Southern California Kaiser has 3.6 million members, and you can read about the size and scope of our organization, but essentially we're a fully integrated healthcare delivery system, and so the problems we're solving, like the opioid prescribing problem, requires large system change approaches.
So let me just tell you how this all started. We were sitting in a small conference room looking at high utilization drugs. We expected to find things such as Cymbalta or Crestor, but much to our surprise, the #1 drug that we found on our list was OxyContin and large amounts of it. So based on this, we decided we have to take a look at what's going on with OxyContin, and later, of course, we peeled the onion back to look at all the opioids. What we found, at least initially, was that a series of patterns that we tended to see. And what it was is that there were really two sides to this equation. And the first side was that we found that there were what I would call the doctor side, where we found a small number of prescribers were giving a lot of this stuff in a lot of patients, and then a larger group, almost everyone else, had a couple patients. So it was both highly concentrated but widespread. The second thing we discovered was that there's a certain, what we call a patient side to this, where certain patients clearly showed themselves under certain patterns. They were willing to travel a long way to see a single doctor. They would be on steadily increasing doses of opioids. They would be demanding brand name drugs, and they would be cascading their prescriptions, i.e. filling a prescription, then 2 weeks later coming back and filling another prescription, et cetera, et cetera.
So I think, one of the things I would just add to Steve's comment is, as we, again, peeled the onion back, we recognize all of the things all of us have read about, the issues of multiple prescribers, the issues of patients, doctors shopping, the issue of patients getting multiple prescriptions from different providers, and also issues about large quantities of opioids being prescribed, either in individual prescriptions or in accumulated prescriptions. So we knew we had a problem. At that point, we basically said, is it just us, or is this something happening more broadly? And I think, again, all of us on this call realize that, like this New England Journal article reflects, there is an epidemic of drug abuse and overdose deaths involving prescription opioid pain relievers. There's almost 15,000 deaths back in 2008 from prescription painkillers. Drug deaths now outnumber traffic fatalities in the U.S. And the prescription opioids that are involved are the ones that we're talking about: OxyContin, Vicodin, Xanax, Soma, fentanyl. There are more deaths from prescription opioids than heroin, cocaine, and benzos combined, based on this kind of CDC reporting. So, the slope of this rate of increase in prescription opioid deaths, and these are unintended deaths, is scary. And clearly there's a community problem, and obviously we're part of the community, and we want to be part of the solution, not part of the problem. The increased use of opioids directly, and the increased deaths from opioids directly follows the increased sales of opioid medications in the United States. And you can see the slope of all of these graphs from sales, deaths, and treatment admissions. The shocker here is that if you look around the world, the United States consumes 99% of the world's supply of hydrocodone products. So we somehow love Vicodin in the United States. That's a problem, because the rest of the world isn't treating pain the same way. And of course, 80% of the world's supply of prescription opioids is consumed in the United States. So, you know, there's a problem here. And we then naturally turn to the evidence. You know, is this appropriate or is this inappropriate? And what do we do about it? So as we looked at the evidence, many of you may remember back in 2000, 2002, there was a campaign that basically was suggesting that we were under-treating pain patients. And so there was a lot of effort, and all of us physicians had to take courses to learn how to treat pain more aggressively. Part of that contributed, I think, to this overuse and overprescribing of opioid medications at least California. But the evidence, when you actually dig down into it, does not support the use of opioids for chronic pain. Opioids have proven efficacy and relative safety for treating acute pain and pain during terminal illness. So we are generally talking about non-cancer pain management. But according to the evidence, opioids do not have proven efficacy or safety for treating chronic pain long term. And in fact, there's new evidence that suggests that chronic high-dose opioids may actually be contributing to pain and pain sensitization. It may be contributing to an inflammatory response called the hyperalgesia syndrome, and may help explain why many patients are saying they need more opioids. Opioids are powerful drugs, even hydrocodone, and should be reserved for serious pain. Underline the word serious. And even the FDA recently, in the last few weeks, has come out reinforcing this fact, especially with the long-acting OxyContin, Opana medications. But 90% of pain complaints do not meet these criteria. Migraines, fibromyalgia, headaches, low back pain. We also learned from the evidence that 90 days is a key point, and is often used as a definition of when you are getting into this chronic opioid use area. Studies have shown that after 90 days of continuous use, opioid treatment is more likely to become lifelong, and it is going to become more and more difficult to take patients off of opioids if they've been on it for 90 days or more.
So this is really a key learning right here. From now on, once people put patients on opioids, whether it be an orthopedist or a primary care physician, you need to really stop and think very carefully. Once you get to that 90-day mark, do I want to have this patient on opioids forever? And most of the time, the answer is going to be no. That's why we call it the 90-day cliff, because once you go over the cliff, there is no getting back up.
Now, the real shocker, of course, is understanding the increasing risk of high-dose opioid use. And this graph shows basically that once you get over 100 milligrams of morphine equivalents per day of opioids, the risk of overdose, and overdose is defined as death, hospitalization, unconsciousness, or respiratory failure, is 8.9 times higher than at lower doses. So clearly, you know, the evidence is telling us we need to avoid high-dose opioids entirely. We also found in our evidence search that others are having different experience with managing chronic pain and chronic opioid use. And the Mayo Clinic Pain Rehab Center provides some information on that. And without going into a lot of detail, the bottom line is they have a concerted effort to actually remove opioids from their patients with chronic pain. And what they have found, surprisingly, is despite discontinuing pain meds, pain decreased. So the program focused on quality of life and functioning, but 73% of the patients who completed their program reported reduction in pain severity at dismissal, despite being discontinued or having significantly reduced their opioids. So this is the evidence. This is the experience out in the community, and this helped us shape the comprehensive strategy that we developed and the intervention strategies and tactics for Kaiser Permanente. And basically, our goal now is to reduce the overuse, abuse, and overdosing of opioids and other controlled prescription drugs while ensuring patients with pain are treated safely and effectively.
So this is what we started with. We said, how are we going to approach this problem? What we started with was we looked at specifically Opana, OxyContin, and brand when generic available opioids such as Norco, brand name Vicodin, et cetera. Why did we pick these targets? Because these drugs are the most likely drugs to be diverted into our communities and schools, and our first priority was decreasing this issue about kids getting on drugs. We all know that the pattern is that kids don't start using heroin. They start on the OxyContin and Opana and Vicodin that we prescribe, gets diverted into schools, and then when they can't get that anymore, they end up on heroin. So what did we do? The first thing we did, and we did this as a group of physicians, this was not done as a health plan benefit. The physicians, both the primary care physicians and the pain specialists and the oncologists all agreed that new prescriptions, new start prescriptions for OxyContin and Opana would be restricted to pain management, oncology, and hospice. The primary care physicians agreed they would not newly start patients on these drugs. The second thing we did, and this was actually key because we found patients getting 3-month massive supplies of these drugs, we set up a benefit issue that we will only give a maximum of a 30-day supply of any of those of OxyContin or Opana and limit it to one refill every 30 days. The third thing we did is we very aggressively, for the reasons I mentioned already, went after the brand when generics are available opioids. There is no reason to prescribe brand when generic opiates, and we basically told the physicians, you need to stop it. In fact, what was interesting is when you looked at patients who were getting brand name opiates, frequently they were getting generics from other doctors outside Kaiser Permanente. That's what we found. The next thing we did is education. I can't stress this enough. Education is a key component to what we do. You can't stop. There's no such thing as too little education. Next, we have Epic as our EMR, and we embedded new decision support tools into Epic, which I'm going to show you in a minute. And the last thing is we set up a culture where our pharmacy would work together with our physicians to evaluate when prescriptions came in that looked possibly questionable. In addition, we went ahead and we used our ability where our pharmacy is integrated with our healthcare system that we were able to generate reports showing who was prescribing what and go ahead and address these physicians that had the high prescribing or patients that were taking lots of medications. We drilled down all the way to a medical center level. At each medical center, we now have a controlled substances committee that meets to discuss these patients or these physicians that are showing up on these high utilizer reports. The last thing is we did find a number of patients who were getting relatively massive amounts of Tylenol containing, acetaminophen containing combination drugs. We saw patients being prescribed 12, 14, 16 tablets a day of hydrocodone APAP, equaling well over 4,000 milligrams a day of acetaminophen, which is dangerous, and we aggressively went after stopping those patients also. In addition, our pharmacy, using a bunch of criteria, looking at such things as distance to doctor, number of providers, number of pharmacies being used, we created a list of the patients at highest risk of diversion by medical center that we then could use to identify patients we wanted to look at more carefully. And the last thing is we actively involved pain management and addiction medicine specialists in this plan. We created open communication between pain management, addiction medicine, and primary care where we wanted the primary care physicians to call the pain management physicians for any questions, or we have electronic communication called doctor advice that we also implemented. So if a primary care physician has any question about any of these patients, they can contact a pain management physician quite easily. The final thing is we pushed making sure there were opioid treatment agreements for every single patient who was on more than 180 days of opiates, or we're on chronic long-acting opiates. In addition, we really encourage the use of urine drug testing to verify the patients were A, taking the drug, and B, weren't taking any other illicit drugs.
So just to comment, Steve just rattled off, 13 things that we've done. This didn't happen overnight. This has been over a 3-year period, and each one of these interventions, as you can imagine, took change management skills. We had to work with multiple specialties: pharmacy, primary care, pain management. We had to work with complex systems, including electronic medical record systems. We were able to use our data and analytics to gather the information that would be presented in an unblinded fashion to physicians and to their chiefs of service, so that everybody was focused on helping to solve and resolve the opioid overprescribing, high-dose prescribing problems that we were uncovering. And lastly, I just want to reinforce this multidisciplinary conversation that we had, where perhaps we're fortunate, but we have pain management specialists, we have addiction medicine specialists, we have our own psychiatrists. There were issues before we sat down in the same room and started understanding each other and how we can function better as a group practice to help support each other. And that really led to the telephonic advice route. These departments, pain management, addiction medicine, were not eager to get a whole lot of new referrals. We don't have enough pain management physicians for all these referrals, but they were willing to provide telephonic advice or even electronic doctor advice on our electronic medical record. And that is really helping to serve us well and providing that sort of safety valve for our primary care physicians to get advice and information.
So let's look at some of the tools that we have, that we prepared. The first one is communication tools. This is an example of what we call medication news. And you can read this, so the print's a little small, but essentially this is information to physicians telling them all about OxyContin. We prepared a whole series of these on these various drugs. Next. In addition, using our electronic medical record, we created what are called, we embedded decision support. And what you're looking at here is an initial alternative medication alert when a physician would order OxyContin. And this would pop up saying, basically, this is OxyContin, there are better, safer alternatives, suggesting the alternatives. And in fact, the alternatives are even orderable right from this screen. Next, and this is fairly unique, this had not been done before. We asked physicians to document in the electronic medical record, and these are hard stops, they had no choice but to document in the electronic medical record why they're using OxyContin or Opana or any of these other drugs. We needed to ask, why are they using this? What else have they tried? Which specialist did they review the case with? And this is really key. We required the physicians to, not that we kept them from prescribing the drug, we just wanted them to document why they were using the drug.
So in essence, this is a just-in-time educational opportunity that forces a physician to really think about whether they're going to sign this order and whether they have, in fact, consulted with pain management and feel comfortable prescribing this med. If they do, they can proceed with the order. If not, we're hoping that they will reassess and rethink their approach to prescribing.
So next we're going to look at what we've been doing basically this year. The first thing we did is we had an educational program where we had 2,200 physicians, basically almost half our prescribers in Kaiser Permanente, physicians in Kaiser Permanente, attended a half-day educational program on how to appropriately prescribe opiates. In addition, we have strongly encouraged cures registration for all physicians prescribing opiates. The second thing we realized is something called the Trinity. If you're not familiar with the Trinity, Google it, but essentially what the Trinity is patients will combine opioids plus benzodiazepines plus soma, and the net result is a heroin-like effect. We did not appreciate this. We now know this exists, and we have extensively educated our physicians not to use this combination. In addition, we have added links in our electronic medical record to an opioid calculator so physicians can figure out the morphine sulfate equivalents of any drug. and we've embedded a link to Cures so they can go into Cures and, again, evaluate the patient in real time. In addition, we discovered, and we think it has to do with the electronic medical record, that we found a number of patients on chronic opioid therapy who hadn't been seen in greater than 6 months, greater than a year, greater than 2 years. Part of it had to do with the EMR and the ability to send emails back and forth. The patients may have been sending emails, and the physician thought they may have seen the patient, but in reality they haven't. So what we did is we are encouraging our physicians to schedule these visits, and we're even identifying those patients who haven't been seen and contacting the physician saying, here's a patient you haven't seen, we recommend that you see this patient.
So I just want to add, the Medical Board of California clearly states that for patients that are on chronic opioid therapy, they should be seen and reassessed on a regular basis, no less than every 6 months. So it was clear that, you know, many patients were falling through the cracks and not getting that level of assessment. And so we are now identifying those patients that have not seen their physician in months and even years and making sure that they get in for reassessment. We're then instructing our physicians and the clinicians on, you know, how to assess those patients and encouraging them to reevaluate and perhaps even taper and discontinue the opioid medication.
The next thing we did is we looked at some of the patients who were getting high amounts of opioids, and we looked at this in 2 different ways. The first way was what we call the super prescriptions, or prescriptions for hundreds and literally over 1,000 tablets at a time of opioids. We set up a system in place, again, working in combination with our pharmacy, that any prescription for any opioid that was in combination with acetaminophen, which would be Norco, Vicodin, Percocet, Tylenol with codeine, any prescription for more than 200 pills at a time would get an automatic phone call from the pharmacist to the physician asking them to please consider only prescribing a maximum of 200 pills per prescription. In addition, we have generated lists and sent them to each physician of all their patients who are on high-dose chronic opioid therapy exceeding 120 milligrams of morphine sulfate equivalents a day. We know these patients are at high risk of overdose and death, and these patients can hopefully be tapered down or even taken off the opioids altogether. Next, we set up strong interdepartmental agreements between pain management, addiction medicine, psychiatry, and primary care. Again, this cannot be solved by either pain management or primary care. Everyone needs to work together to manage these patients. Lastly, and we've done this most recently, is we've recognized the issue about injectable opioids. We found a surprisingly moderate number of patients who are getting significant, almost sometimes 2-3 times a week, injectable opioids for chronic pain. And we have a policy coming into place on January 1st that we will no longer do this. Patients who go to the emergency room or urgent care asking for an injection for opiates for chronic non-cancer pain will not be receiving those injections. This has already been done in San Diego quite successfully.
And I'll just interject, this is based on new guidelines and recommendations that have come out from the American Academy of Emergency Medicine and the American College of Emergency Physicians. And it's based on evidence that supports the fact that patients who are already on chronic opioid therapy derive no additional benefit by getting an injectable medication on top of that. Essentially, they're already maxed on opioids, so it's really questionable practice and no longer standard of care to be giving injectable opioids to patients who are already on chronic opioids.
In addition, for our ED and urgent care, we set up guidelines in terms of what they were going to prescribe. There was the old idea that the patient would go to the emergency room with and they had a sprained ankle and they go home with a bottle of 100 Vicodin. This is not good practice of medicine. What we've done is we set essentially a guide of 1 week supply for a patient who presents to the urgent care or the ER with an acute pain issue. In addition, patients who are already on chronic opioid therapy, we set a guideline that they would only get a maximum of a 3-day supply in those cases if they ran, or even 0 if they ran out of their prescription, etc.
And then lastly, and I'll switch to the next slide, there's a community health opportunity here. This is clearly a public health issue, the epidemic of chronic opioid treatment. And San Diego County had developed a coalition, a collaborative among the Medical Society in San Diego, the Hospital Association in San Diego, the Department of Health Services in San Diego, and essentially use these same emergency medicine guidelines to develop a community-wide initiative that they have now implemented, whereby all emergency rooms in San Diego and Imperial counties are following the same guidelines that we just outlined. Injectables are to be avoided. Small doses of oral opioids would be dispensed. Refills of medications, of opioid medications for reported, I lost my prescription, the dog ate my prescription, or my prescription was stolen, will not be filled in the emergency rooms. So it's setting a standard of community practice in all of the emergency departments in San Diego. This is essentially what we're adopting across all of Southern California Kaiser Permanente, and we've begun working and have had conversations already with many stakeholders in the County of Los Angeles to try to move this practice to become a community-wide practice among all emergency departments in the County of LA, and then we're going to move on to other counties, Orange County, San Bernardino County, and hopefully statewide. And here's where I would interject. I think hopefully many of the people attending this conference today can be part of that solution, and we'll talk a little bit later about the kind of opportunities we have to start collaborating together. So now that we've outlined sort of what we learned, the shock we had when we found OxyContin was our #1 prescribed, non-formulary medication, the evidence that we reviewed and that we then applied to the strategies and interventions, I want to share with you some of the results that we've achieved. First of all, our OxyContin prescribing from 2009 or 2010 to today has dropped by 80%. Very striking. And clearly, we have reduced the amount of OxyContin use without sacrificing appropriate pain management. We like to feel that we've reduced the quantity of OxyContin that is getting into the streets and being diverted that's contributing to these non-prescription opioid deaths. Secondly, we've paid attention to and have been tracking the use of high-dose opioids. I mentioned to you that greater than 100 milligrams of morphine equivalents per day was associated with a almost 9 times greater risk of death or overdose. So already this last 12 months, we've reduced the number of members on high-dose opioids by 21%, and we're still going strong. And lastly, the brand opioids, when generics are available, brand opioids have much higher street value. Vicodin by name can sell for $20 a pill on the street. Hydrocodone acetaminophen generic won't sell. So, we've been focusing very strongly on reducing the brand prescribing of opioids, and as you can see, we've essentially almost eliminated brand opioid prescribing when a generic was available.
And again, this is really key because these are the drugs that can end up in our schools. So this is really, this combined with the reduction in OxyContin and Endopana, by the way, is really a significant, we have significantly reduced the supply of opiates in Southern California, of the opiates subject to abuse in Southern California.
So, lessons. What have we learned through this journey and through this process from discovery to today, where we're still in progress? There's still work to be done. We're not satisfied yet with where we're at. But again, hopefully we are part of the solution to this opioid epidemic and not part of the problem. One is leadership. I think it's very clear that without someone like a Steve Steinberg and some of the other leaders that we've had in the region, this kind of initiative, these kinds of results would not happen. So there needs to be very, very strong and committed leadership. We can't give lip service to the fact that, oh, there's an opioid problem and we'll just send out a few memos and the problem will go away. We have to doggedly nag, nudge, provide data, have those difficult one-on-one conversations with our providers, make sure the evidence is understood, and it's our feeling that that really is leadership-driven. It requires a lot of change management skills. I think that's understated. What we've also learned, though, is that prescribers need support. I always take the attitude that our clinicians, our physicians, none of them are out to do harm to our patients. But we've adopted certain practices basically over time and historically, and through misinformation and sometimes through pharmaceutical advertising. So, we need to get back to the evidence. And the evidence, we've been communicating. We need to re-educate our physicians around appropriate opioid use. We certainly have put a lot of effort into providing decision support. You saw an example of that in our electronic medical record. And then this concept of reinforcement. This is not a one-time communication. This is not a one-time effort. We need to be repeatedly reminding and reinforcing this as we go along. And that the last bullet basically is communication, communication, communication. The other lesson, of course, is this does require multi-stakeholder collaboration. It's among multi-specialties, and it's among the pharmacists and the providers. And so the more collaboration, the more cooperation, the more forums where we can jointly problem solve, share a vision of our goals, the more likely we feel that you're going to achieve outcomes. And then lastly is data. Data is very important to show, one, not only where you are and the progress that you can make, but data is really important to show individual clinicians, patient by patient, where there are opportunities to reduce doses, to reconsider opioids or alternatives to opioid treatment for chronic pain. And again, I can't underemphasize how important data has been in helping to inform and instruct and reinforce the progress that we've had. Lastly, again, I'll just reemphasize the call to community action. I think it was demonstrated with the San Diego County work, and we're trying to take a lead and be part of a process to, build more community collaborations to start addressing some of these opioid prescribing issues. First starting with the emergency department, but I would venture to say it affects other urgent care centers, primary care, the handoffs to avoid doctor shopping among physicians in the community. I think there are opportunities, and perhaps it'll come up in our discussion, about how we could start working together to really have a much greater impact on this opioid problem in California. And with that, we come to the part of the program where we're very interested in any of your comments, any questions, and any of your experiences in dealing with this opioid problem. Thank you very much.
Great, thank you so much. So we do have several questions queued up, and I would encourage other folks to go ahead and put other questions into the chat function. If you would like to make a comment, I think you can raise your hand above the chat function. If you had the system call you, you can raise your hand and Canal can unmute you. So I'll just start with the questions that were queued up. What percent, this was earlier in your presentation when you talked about the agreement with patients, what percent of patients drop out of the pain med request when asked to complete the opioid agreement and urine testing?
Can you repeat the question one more time? What percent of the patients walk away essentially when we ask them to do the opioid treatment agreement and urine drug screening?
Correct.
The biggest problem, I don't know if I can give you that answer, but the biggest problem that we did see is that the primary care physician would correctly recognize that these patients were a problem. They would order this. They would do opioid treatment agreement. They'd order a urine drug screen. They'd try to refer the patient to pain management. The patient wouldn't go, and then the physician would keep on prescribing. I don't think it's a large number, but the biggest issue was not that the patients wouldn't do it, it's that they wouldn't do it and they kept on getting the opioids afterwards.
I would also add, as we brought this up, there was a lot of anxiety by physicians that this wouldn't be received well by their patients, when in fact that's not been the general experience. Patients actually have been very receptive, and I think it helps communicate the risks and benefits of opioids, and communicates that these are serious and important medications, and the patient has a role and actually commitments to make sure that this is prescribed safely. So we had to sort of overcome the physician anxiety barrier more than the patient anxiety barrier.
Okay, thanks. And Catherine from Silver Avenue, I see that you have your hand up. I don't see a phone icon next to your name, however, which means I think that you called into the system, so we can't unmute your line. But if you have a question or a comment that you'd like to make in the chat function, I can take it there. Second question, do you see the same risk with OxyContin since it has been reformulated, or does it now have a place in therapy due to its tamper-proofing?
You know, we thought that OxyContin would go down in risk, but I don't think it has. It has such a, what's the right word, brand presence, shall we say, in the market, that it still has a significant street value. It still has the same risks of diversion and abuse that we've seen before.
And more importantly, it's really the morphine equivalents that are important. And OxyContin is a very potent medication, whether it's the immediate release or the sustained release or long-acting medication. So I don't remember what the conversion factor is, but I think it's 3 to 2 or something like that. But it has a very high morphine equivalency, which means you very quickly reach that 100 milligram or 120 milligram morphine equivalent dose level, which is a very, very high risk, high dose level of opioids to be giving to patients, given what we've seen about the risk of overdose, death, and hospitalization.
Yeah, actually, a better answer to the question is that it's not that OxyContin is any safer than it was, but it's clearly now safer than Opana. Opana actually is a 3-to-1 to morphine, and Opana is very easily abused, and that's probably our highest risk drug at this current point. So I wouldn't use either one, but I certainly wouldn't use Opana, which is oxymorphone.
Okay, thanks. You mentioned in the results to date section at the end of your presentation that you reduced OxyContin use without decreasing effective pain management. How did you measure how well you were helping patients manage their pain?
Well, a couple ways. One is, our physicians are have been very attuned and very sensitive to the fact that they didn't want patients to suffer. They didn't want to sacrifice pain management, and so, they've been holding Steve and I to the wall. As we are recommending tapering, as we're recommending reductions and discontinuation, we have not heard, issues coming from the physicians on that. Secondly, we do monitor patient complaints, member complaints, and while there were a few member complaints, basically, why are you taking my OxyContin away? They weren't complaining that their pain wasn't being treated. In fact, we got them into pain management, and we felt that many of these patients who are very complex patients, we have to be honest here that many of these patients who have been on chronic opioids for chronic pain are very difficult. They have other issues, behavioral health issues, other issues that affect them, and they're very complex. So in many cases, we were simply able to get better consultation, advice, and in many cases, referral to pain management where, it's our feeling that they got better better care in the long run.
Okay. What about methadone overuse? Did you look at that in this initiative, or did the data show anything about that?
Well, methadone is first of all, methadone we know is the most dangerous opiate that we have. The risk of overdose and death is the highest in methadone than in any of the other opioids, except for maybe oral Demerol. In addition, methadone has the issue with the EKG changes you can see at high doses. The answer is we're still discussing what the appropriate role of methadone is in pain management. In low doses, I believe it's a safe drug, a perfectly safe alternative. I think it can be prescribed after consultation with a pain management physician by a primary care physician. Again, in low doses. In high dose methadone is a different story, and for that, those patients should be seen in pain management and really be followed in pain management.
I think what impressed me, and I guess Steve has told you, we haven't really resolved the methadone issue and challenge yet, but we are studying it. We're looking at the evidence base, and what I've observed is the morphine equivalent of methadone really is transitional. It's dose dependent. The higher doses have higher morphine conversion ratios than the lower doses, so it sort of agrees with Steve's point that the higher dose methadone, we're going to get into problems. So this is a work in progress for us, and maybe we can report back to you at another time.
But again, low dose methadone in the properly selected patient is quite safe.
Great, thank you. We have about 3 questions left, so if there are others on the phone who have questions, I think we'll be able to address a couple more, so please chat them in. What about Suboxone for chronic pain? It's a low-risk alternative that's not FDA indicated but could be hugely beneficial in the treatment of chronic pain.
So let me start. Steve, I know, has a lot to say about this. When we sit across the table with our pain management and our addiction medicine physicians, they clearly are telling us Suboxone is not an appropriate medication to be used for chronic pain. It's really a drug to be used for addiction management, and we have not, therefore, gone in any direction of off-label use of this for chronic pain. So we've really avoided that. Steve?
In the community, we are seeing pain management physicians using Suboxone for chronic pain. We have a small number of patients within Kaiser Permanente who have been given Suboxone for chronic pain, but in general, we discourage it. And primary care physicians should, and we feel, should not be prescribing Suboxone under any circumstances.
Okay, thanks. Next question. Did you look into the effectiveness of cannabis for pain and whether it had an effect on diversion and or overdose of opioids?
The short answer is no, we haven't.
Okay.
Although there's a big debate in the pain management community about whether patients who are on chronic opioid therapy should be on marijuana or its equivalents or not. There are many pain management physicians who feel that because of the various drug interactions that it does have, that patients who would use marijuana are not good candidates for chronic opioid therapy. There are other ones who disagree with that. This is an in-evolution issue.
Okay, thanks. Next question. You discussed a lot of patient outreach at the point of urgent care and ED prescribing. Did you guys do general outreach to patients in primary care who were getting chronic pain meds so that they were prepared to have the discussion with their PCP?
That's a very good question, and no, we did not do patient outreach. We were very sensitive to the fact that this conversation needed to be initiated not through a letter, but by the physician, in a doctor-patient conversation. So, other than the fact that there may have been some general communications in some of our health plan publications, and certainly if you go to kp.org, our member website, and you may be seeing information and messages about the opioid issue in America. we did not send any patient-specific letters to our members. And related to that is, as we are implementing this emergency department and urgent care initiative, just like in San Diego, we, because of EMTALA issues and HIPAA issues, the handouts, which I showed you, in fact, let me see if that handout, we are going to be handing out to every member who visits our emergency room, which is what they're doing in San Diego. So we're not just handing it out to patients who were coming in for pain or who are on opioids. So it's basically communicating to every member in the community who visits our emergency rooms or any of the emergency rooms in San Diego that this is the standard of practice for opioids.
We did debate this issue, though, about whether we should send out letters to the patients, and we finally decided, for all the reasons that Dr. Hyatt mentioned, not to do that.
How were the conversations different with the PCPs versus the emergency medical, the EM, the ED docs?
Well, the ER docs are actually easy because their own society, the AAEM, has come out with a recommendation not to do this anymore, not to give out these injectable opioids. So they were all, in fact, they kind of came to us and said, hey, we want to stop this. The issue with primary care is a little more complicated. And, there's this whole concept about good doctors versus bad doctors. These primary care physicians who ended up with these patients who were on these, we'll call them relatively high doses of opioids, these are not bad doctors. They sort of got themselves into a situation that was not, that they didn't mean, they ended up in a place where they didn't mean to go. So, and these people really, truly believe that they were doing the right thing for the members. It was difficult when we approached some of these physicians and said, hey, this patient's taking 300 milligrams of OxyContin a day, for chronic migraine headaches. This is not a good thing. This was a difficult conversation. These physicians, they meant well, and they simply got into a situation where they didn't mean to go.
What I will add, though, is as we have been rolling out some of these other initiatives, so for example, the quantity alerts, the quantity flags, where I think Steve mentioned that any prescription for a hydrocodone product or a oxycodone acetaminophen product that gets to our pharmacy of 200 tablets or more, the pharmacist will be calling the physician. I can't tell you, I've gotten so many calls and emails from physicians thanking us for instituting these kinds of initiatives. And the 30-30 policy, where some of these very high and potent opioid medications like OxyContin and Opana, and we're hoping to expand this actually to all Schedule II opioid medications, can only be prescribed for a 30-day supply and cannot be refilled in less than 30 days. Our physicians have written thank you notes to us because it is allowing them to have a better conversation with patients, saying simply, this is the way we practice now. This is how serious we feel opioid prescribing is as an issue, and for your own safety, these are the limits that we're practicing under.
Again, these are not bad doctors. They just got themselves into situations they didn't want to be. Of interest is we found no physicians who were selling drugs or any signs of any horrible misuse. Again, these are all good doctors who just ended up in, shall we say, bad places.
And I'd like Steve to expand a little bit about that. We evaluated some of these patients to try to understand how did they ever get to be on such high doses of opioids. And as Steve will explain, this happened gradually and incrementally over time.
Yeah, what we saw was we saw a recurrent pattern over and over again where the patients would keep on having pain, and what we saw was an increase of, we call it the 36 rule, where 30% increase every 6 months. So patients would initially start off on smaller doses of opiates, but give it 2 or 3 years at a 30% increase every 6 months, and eventually they were on literally hundreds of thousands of milligrams of morphine sulfate equivalents a year.
And it was really questionable. And again, if you refer to the Mayo Clinic experience and other now published experiences and the issue of the hyperalgesia effect, patients may actually have been getting worse while on opioids because opioids causing this inflammatory effect, and or they were just being dependent and their true pain problem was not being addressed, which in our minds means that they really deserved a pain management evaluation rather than just continued escalation of their opioids. So we've been learning a lot about this, and our physicians have finally gotten the message, and basically, again, have been appreciative, honestly, in the long run. Not that it wasn't easy, that it was so easy at the beginning, but persistence, anchoring ourselves in the evidence, reinforcing, as I said before, the message has gotten through that opioids are not effective for chronic use, and so that should not be our pattern of practice.
Okay, one last question I think we have time for. There was a comment about the importance of getting at the importance of engaging PCPs because they control obviously control the prescribing, and I think you reiterated that. Last question, did you put any restrictions on concurrent benzodiazepine use?
Great question. We are just starting to look at that. Again, this comes back to the Trinity question, or the combination of opioids plus benzos and opioids plus benzos and muscle relaxants, particularly soma. And the answer is we are going to be starting to run those reports, and we think the wave of the future is that patients who are on chronic opioid therapy should not get a benzodiazepine unless they have a documented anxiety disorder and the prescribing is done by a psychiatrist. But we have not gotten there yet, but I think that's where we're going to go.
We have collected the data, and we have identified the patients that are on these combinations of opioid, benzo, and muscle relaxant. So we are about to engage on alerting our physicians to these individual patients and encouraging them to, consider discontinuing one or two parts of that trinity.
Okay, thanks. And I think there was interest from Wendy, the person who had asked about the Suboxone, to continue the conversation. But it sounds like we don't have time for that now. But I also asked if she wanted to unmute her line, but I didn't hear back. So if there's a way that we could share your contact information, if you're comfortable with that, we could do that offline. And just to reiterate that we will be posting both the slides and a link to the webinar recording, and also posting a 2-page summary of this initiative that was shared at the CAPG annual conference earlier this year. And I'll just go here to the slides. This is the link where everything will be posted, but again, we'll send out an email to everyone who registered. Thanks so much to Drs. Hyatt and Steinberg for your time today. We really appreciate the detailed presentation and sharing your approach and story. And thanks to everyone who joined us on the webinar today.